Hi, everyone. We congratulate today Dr. Sankar and Dr. Hayden Danyluk with amazing achievement editor's article choice of Dr. Sacco Cephalalgia. Please welcome, please read the article, but we have this wonderful choice of the editor and talking today to authors of the article. Please, Dr. Sankar, tell us a little bit about you and maybe then we can hear about article itself.
Well, thank you, Dr. Riggins. It's really a great honor for our paper to be selected as this month's editor's choice in cephalalgia. I am a neurosurgeon, so perhaps not necessarily the core audience of cephalalgia, but it's a journal that certainly we have been following for a long time. And in fact, along with Hayden, Dr. Danyluk, we've published in cephalalgia a few years ago as well. And so this is in a sense a follow-up publication on some work that we've been doing in the area. As I said, I'm a neurosurgeon. I'm based at the University of Alberta in Edmonton, Canada. I am a functional neurosurgeon, so I deal with, among other things, the treatment of chronic pain and chronic facial pain with a specific interest in trigeminal neuralgia. And of course, who could not be fascinated by this disease, which used to be called the suicide disease? Terrible facial pain in the distribution of the trigeminal nerve, and one which neurosurgeons are involved because a number of patients become medically refractory, and then we can offer surgical therapies, which are quite effective. But the genesis of this work relates to trying to understand why, even after initially successful surgeries such as microvascular decompression or percutaneous rhizotomy, in our case, balloon rhizotomy, why there are these divergent responses. Many patients will have a great pain result immediately, but then in time, there will be recurrence of pain. And this problem has been a preoccupation of ours in our lab for the last several years. And we've applied neuroimaging techniques to its study primarily, but also more recently neurophysiological techniques and even some biochemical techniques. So this is all part of a program to better understand the pathophysiology of trigeminal neuralgia and also its response to surgery and therapy in general.
Thank you so much. That's an excellent introduction and background. And I know that Dr. Danyluk is our expert on methods, I was told. Could you please tell us, as first author, and about methods that you use for this article and research?
Yeah, absolutely. And first of all, just so I did my PhD with Dr. Sankar, and now I'm studying radiology as a medical doctor at the University of Calgary. Um, I think a big part of this article was the methodologic design we used. Taking pictures and the brainstem with MRI is inherently challenging because of various soft tissue interfaces, bone interfaces. There's a number of sinuses in that area as well. And this distorts the magnetic field, making things very challenging. In particular, we wanted to use a type of imaging called diffusion tensor imaging, which I'm sure as a neurologist you're familiar with, which is really highly tuned to look at white matter and nerves. Unfortunately, this particular type of imaging is quite challenging in that area of the brainstem, for the reasons that I've already mentioned. And so the first point of this work was to move ahead and develop a more accurate method, or a better method, to look in this region of the brain at cranial nerves. And so we did this by improving the resolution, sharpening it to a very, very tight 1.2 millimeter isotropic voxel. And then we also combined fluid attenuation with our MRI protocol to suppress contaminating signal from the surrounding cerebrospinal fluid that may be leaching into our nerve signal. And so that was the core goal with these methods. We conclusively showed in some other work that this method was superior to look at the trigeminal nerve, and then rolled it out in this particular study to examine patients and characterize how their nerve changed with surgical treatment. And then distinguish nerve change between responders and non-responders.
That's fantastic. What were the results?
Yeah, so the as Hayden mentioned, the goal was to use this method to look at the trigeminal nerve using diffusion tensor imaging and specifically tractography to then look at the microstructure of the trigeminal nerve before and at multiple time points after surgery in patients who are undergoing surgery for trigeminal neuralgia. So we had a population of patients who were medically refractory and they were then chosen to undergo surgery. If they had classical trigeminal neuralgia, that is with neurovascular compression of the root of the trigeminal nerve, then they underwent typically microvascular decompression or MVD. If they did not have that, or if they chose not to undergo that invasive a procedure, then they were offered percutaneous rhizotomy. And we followed these patients for a period of time, and we followed their pain outcomes. And we defined response as being completely pain-free. So this is somewhat of an interesting difference in our study compared to others in the trigeminal neuralgia field. We chose a very binary response. Are patients pain-free or not? And that was our threshold for response. So those who immediately after surgery were pain-free and remained pain-free at 2-year follow-up, those were the patients that we considered to be responders. So it was a more stringent threshold for response. Based on that response, we then categorized these patients into responders and non-responders, and we looked at the microstructure of the trigeminal nerve, and we found something very interesting. Previous work had shown that perhaps on the affected side of the face, the trigeminal nerve has some microstructural abnormalities. These are measured using typically a metric called FA, or fractional anisotropy. So we did see some of those differences, but I think to highlight the key finding was that beginning right after surgery and quite apparent by 1 month after surgery, we noticed that in those patients who go on to be long-term responders to trigeminal neuralgia surgery, that they have this marked decrease in this FA within the trigeminal nerve. And this is along the whole segment of the trigeminal nerve from the brainstem to the skull base. So when I do an operation, I'm operating in this area, largely if I do a microvascular decompression. If I do a balloon rhizotomy, I'm just a little distal to that. So that is, at the Meckel's cave where the trigeminal ganglion sits. And so we find that by 1 month, you are seeing these fairly dramatic changes in the microstructure of the nerve, but those are only in patients who go on to have long-term favorable outcomes. We then also saw that, maybe much to our surprise, that there's not some kind of reparative phenomenon that is happening within the nerve. We often think of trigeminal neuralgia as being related to demyelination, and that perhaps one of the mechanisms in terms of successful surgery would be remyelination in time. But what we find is that these microstructural changes, this decrease in FA in responders, remains diminished over time. What's more is we had a unique set of a subset of patients who underwent multiple surgeries for trigeminal neuralgia. And this is often, unfortunately, the clinical case in this difficult to treat condition. Patients will have surgery, they'll do well for a period of time, and then for reasons that are not understood, they'll have pain recurrence. And what we found when we followed the nerve microstructure in these patients, the FA indeed goes down initially during that response phase, but then as the pain returns, their nerve returns back to that preoperative state where the FA is once again high. And again, this seemed a little bit paradoxical, but it certainly says that the microstructure of the trigeminal nerve is very closely linked to the response to surgery, and that we as surgeons, or those of us who are intervening, almost have to induce some kind of change in the nerve in order to have durable pain effects. So that, in a nutshell, is the summary of the results.
This is fascinating. So, what would be the conclusion?
Go ahead,
So
Hayden.
I think, of course, so I think that exactly what is happening to the nerve and how this is related to pain relief, it is somewhat speculative at this point. But the way that we interpret the findings is that inducing this microstructure change and this specifically the reduction of FA, this suggests that there's a bit of a disruption in the integrity of the nerve. So perhaps a nerve injury that's induced by surgery. And so, simply put, surgery seems to, it must do some amount of injury or initiate some amount of microstructure change in order for patients to experience the pain relief. I think this has to do with inhibiting or perhaps reducing the hyperexcitability of the trigeminal nerve, which is known to be the case in patients with trigeminal neuralgia, at least in the immediate phase. And then more longer term, which we haven't as of yet studied, perhaps provide enough of a pain window or a period of reprieve to allow for downstream brain change to occur, perhaps even undoing the compensatory mechanisms that have been characterized in patients with long-term chronic pain.
That's
Yeah, I would also add.
amazing.
Yeah, thank you.
Please.
I would also add that I think one of the damage that Dr. Danyluk alludes to, I think is more of a micro lesion. No one is
Mm,
suggesting that it's dramatic damage. Certainly, we used to think that when we would do a microvascular decompression, which involves, of course, a craniotomy and then moving a blood vessel away from the trigeminal nerve, that one ought to be quite delicate, right? And of course, we do need to be to avoid vascular injury. But there has always been this sense that you can manipulate the trigeminal nerve, and that when you do so, perhaps that has been linked to a longer term response. Our results would suggest that there is some validity in that thinking, so that you want to, of course, be delicate, but that perhaps manipulating the nerve slightly is required in order to have the ultimate long-term effect. What we haven't been able to answer with this work, and this is going to be some of the next step, is why these two different surgical procedures, which are done at different sites along the nerve, and one of which is the rhizotomy, which is more injurious to the nerve intentionally, seem to have the same nerve change profile microstructurally after surgery. You might expect them to be different, but we found that it was actually quite similar. Another thing is that in the clinical world, when we do these procedures, patients who have microvascular decompression after surgery, they tend not to complain of much numbness, or it's very mild. Whereas, of course, with rhizotomy, we often induce numbness, and at least temporarily. And we tell patients, when we induce numbness, that means the operation has been a success. So why would then the nerve look the same microstructurally after these two procedures? That remains something that's uncertain. And then finally, why is the overall pain relief with microvascular decompression over time superior to that of percutaneous rhizotomy? To some extent, that might be a selection bias. We know that patients who have classical trigeminal neuralgia with neurovascular compression tend to do better with either medical therapy or surgical therapy. And more often than not, those patients are offered MVD as opposed to percutaneous rhizotomy. Where we were more likely to treat idiopathic trigeminal neuralgia patients. But I also think that the procedures themselves are doing something different, and that also needs to be teased out. We did not study gamma knife or stereotactic radiosurgery in this study, and of course that's a popular modality to treat trigeminal neuralgia as well. It remains to be seen how the nerve behaves after gamma knife. There is some work that has been done in that area, but we're interested in that as well. So certainly some unanswered questions.
We are very grateful for you to continue working on that. And I really hope that our audience will read this article, use it in their practical life to think about patients with trigeminal neuralgia and approaches to treatment. And I definitely hope that we see a lot of your new articles and research in cephalalgia. So thank you so much.
Thank you. Yeah, and we
thank you.
really we really look forward to publishing again in future.